Hello, everyone. Welcome to the Patient Empowerment Educational Series. My name is Tia Tomlin, and I'm the co-founder of My Style Matters and will serve as your moderator for today's topic on cancer, COVID, and disparities. On behalf of My Style Matters and Cancer Awareness Network, we'd like to thank you for joining today's session and hope that you will join future sessions. To learn more, visit www.mystylematters.org and click on the News and Events tab. Before we get started, I'd like to thank our sponsor, Amgen. Today, you will be hearing from Dr. Otis Brawley, Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. Dr. Brawley is a board-certified medical oncologist and epidemiologist. He is an authority on cancer screening and prevention and leads a broad research effort of cancer health disparities at Johns Hopkins School of Medicine, Bloomberg School of Public Health, and the Sidney Kimmel Comprehensive Cancer Center, focusing on how to close racial, economic, and social disparities in the prevention, detection, and treatment of cancer. From 2007 to 2018, Dr. Brawley was the Chief Medical and Scientific Officer of the American Cancer Society. He is the recipient of the U.S. Public Health Service Meritorious Service Medal, the Department of Defense Distinguished Service Award, and the 2019 American Medical Association Distinguished Service Award. Dr. Brawley is also a member of the National Academy of Medicine. Dr. Brawley, welcome and thank you so much for joining us today.
It's wonderful to be here, and I always enjoy talking to survivor groups and support groups. I'm going to talk about the coronavirus and cancer and a little about the health disparities issue with the coronavirus, and then we can open it up to questions. But I think everybody knows that we started having a problem in the United States. We're starting to realize sometime in January. The coronaviruses are a series of RNA viruses for folks who've done, if you can remember your high school biology. These are not DNA viruses, these are RNA viruses. There are a number of coronaviruses out there. Almost all of us have had a coronavirus in the past. We thought of it as a bad cold or as a bad flu. But all of us have had coronaviruses. This particular coronavirus called novel COVID-19 or SARS-CoV-19 is especially contagious and especially difficult in terms of it causes a lot of respiratory problems and it causes people to get very sick. Indeed, it's looking like about 2% of people who get this virus die from it. It might be as low as 1%. And the reason we don't know all of this is there seems to be a goodly number of people who get this coronavirus, this particular one, and have minimal symptoms or maybe even no symptoms at all. Perhaps half of all people who are infected with this disease have no symptoms or minimal symptoms, and then half start having the more severe symptoms. And it's about somewhere between 20 to 30% of people who are getting this who are so sick that they end up being hospitalized. Of people who end up in the hospital, they most commonly end up in the hospital because of respiratory problems. And that respiratory problem is the one that's gotten a lot of press. A number of people have such respiratory difficulties that they can't breathe very well and get put on a ventilator. And that's a very serious situation because in most hospitals in the United States, it's only 1 in 5 or so people who get put on a ventilator who are actually able to come off of it alive. So again, a couple of descriptors here. It's a SARS virus. SARS is our RNA viruses. SARS stands for Severe Acute Respiratory Syndrome, or SARS. Other SARS viruses that you have heard of, there are many that cause colds and flus, but you probably have heard of MERS, Middle Eastern Respiratory Virus, which was a problem about 10 years ago. It crossed over from camels in the Middle East. These are all zoonoses. These are viruses that occur in other animals and then cross from those other animals over into humans. We think this particular virus came from bats and crossed from bats to other animals and then on to humans. Some of you who listen to the news a lot might hear that the current administration has some other theories, but most of us do suspect that this came naturally from a wet market in China, from bats to some animal, and that animal spread it to humans. The swine flu, for example, we've had several swine flus over the last 30 years, comes from pigs. The SARS outbreak that occurred in 2006, that was especially hard in Hong Kong and Toronto, came, we think, from chickens. Now, when we talk about SARS and cancer patients, couple things. People who are immunosuppressed are especially set up to have bad outcomes from this. Many cancer patients are immunosuppressed because they get chemotherapy. Not the hormonal therapy like tamoxifen or the serum estrogen receptor modulators, but hardcore chemotherapy. And people who've gotten just 3 to 6 months of chemotherapy are often immunosuppressed 2 years later. This virus has been especially hard on the Black community in the United States. And it's actually, if you understand the virus and understand some of the health problems, this is not such a surprise. This would have been predictable. The SARS type viruses with this sort of contagion spread to people who live close to each other. That's why New York has had a problem, because the density of people in New York is very, everybody's very close. And of course, poor people, minorities being poor very frequently, have jobs and have other social situations where social distancing is not really an option. And so they're more likely to get the virus because of their work situation, their living situation. People who have comorbid diseases are more likely to not do well from this virus. Our whole history of health disparities and health inequity tell us that these are the same groups of people who have higher rates of obesity, higher rates of diabetes, higher rates of hypertension, higher rates of a number of comorbid diseases that parallel with poverty. And so we're starting to have the perfect storm here. We have minorities and poor people who are living in situations that help to spread the virus, and these same minorities and poor people have many of the comorbid diseases that help not be able to overcome the virus. Actually, the biggest comorbidity associated with death from COVID-19 is obesity. And of course, 80% of Black women in the United States are either obese or overweight. Overweight is not as bad as obese. I think the obesity rates right now among Black female adults are in excess of 60%. And it has been a huge, huge factor when we look at populations with coronavirus and death. Other comorbid diseases that increase risk of death include hypertension and diabetes. They're part of the reason, the technical reason, the spikes on the coronavirus, if you've seen the pictures of what the coronavirus looks like, those spikes are the corona for which the virus gets its name. Those spikes actually bind the virus to a cell wall, and they tend to bind to, we call them ACE, pardon the siren behind me, we call them ACE receptors, angiotensin converting enzyme receptors. Angiotensin receptors are something that's involved in the treatment of hypertension. Many people take angiotensin converting enzyme inhibitors. They usually end in pril, like lisinopril or captopril, enalapril. The receptors those drugs actually block synthesis of angiotensin. Angiotensin wants to go to these receptors that the coronavirus will bind to, that we have in our lungs and our blood vessels and other things. And that's how the coronavirus actually gets into our cells and actually starts causing problems. Other thing I will note is we have had a failure of our public health system that has caused the United States to have such a high death rate. There are well over 70,000 Americans who have died from this disease so far. There are about 225,000 people who've died from it around the world. Why a third of all the deaths are in the United States so far? It's because our public health system has not been able to mobilize and control the system. If you look at control the disease, if you look at Italy and Spain, which were hit hard early on, their public health system was able to get on top of it. If you look at Germany, or even come to the United States, look at the state of Washington versus the state of New York. The public health system in the state of Washington was able to close things down. First, realize there was a problem, and second, start closing things down quickly, and that prevented some of the spread earlier on. When we say prevent the spread through closing down, it's actually very simple. Unfortunately, we live in a complex society, so it's hard to get to this. If we could get everybody to just stay home and not come in contact with other people other than a very close immediate family for 2 weeks, the cycle would be broken, and this virus would not keep spreading throughout the population. What we really need is the discipline to shut this country down totally for 2 weeks. We've tried these half-hearted shutdowns, and it has slowed things down. Dr. Fauci and Dr. Birx refer to that as flattening the curve. Now, what flattening the curve did mean is that we have not overwhelmed our hospitals with lots of people in a short period of time. We've chosen to send those people to the hospital over a longer period of time. With the opening of the country that's happening right now, we will see continued numbers of people dying. Many of us do anticipate that there will be a boomerang later this year, probably in September, October, where we're going to see this virus come back, and we're going to see more and more people harmed by it. Now, when we talk about contagion, the things that we can do to prevent contagion, even when we have an opened up society, involves social distancing, it involves a lot of hand washing, and it involves really trying to avoid coming in contact with the ways this thing is spread. When I talk, particles of my saliva, small particles of my saliva, go 4 or 5 feet out in front of me. If I'm singing, you don't want to hear me sing. But if a person is singing, their saliva can go even further. If a person coughs, it goes even further. Now, people who breathe that in actually can have virus in those little particles, and that virus can get into our lungs and can cause us to get infected. not just into the lungs, it can get into the mouth. The other way that people can get infected is if someone were to sneeze on a desk or elevator buttons or any hard surface, and then someone touched that surface and then touch their eyes or their nose or their mouth, that's another way that the virus can get into one's body. Hence the importance of hand washing often and hand washing very well. Don't forget the thumbs. Don't forget to get up around the nails and in between the fingers. Hand washing very often. And then this mask thing. The idea of the mask has been terribly misunderstood by Americans. The way to think of it is, unless you are wearing a fitted N95 mask, and we'll talk about that in a second, unless you're wearing a fitted N95 mask, the mask that you wear is not to protect you from inhaling those little particles that might be in the air from somebody else. Is to prevent you from putting those particles further out into the air. The mask actually stops those particles as they're leaving your mouth. Some of them still escape through the mask and may go 1 or 2 feet, but they're much less likely to go 3, 4, 5, 6 feet. One of my colleagues said that what we should be telling people is not wearing a mask it's not suicide, it's homicide. You wear the mask to protect other people from you. In the United States, we have a culture of doing things to protect ourselves. A lot of people think they wear the mask to protect themselves. That is not the case. Now, N95 masks that are properly fitted actually do help to decrease the amount of virus an individual will breathe in. When I say properly fitted, in the hospital, they don't allow men with beards to wear N95 masks because the N95 mask has to be properly sized and fitted to the face. And when we size and fit an N95 mask to a face, we actually put it on the person, get it adjusted so they know what it's supposed to feel like when it's on. And then we spray a liquid in their face. And we say, if you can actually taste the sweetness in that liquid, that mask is not on correctly. And so that, this is something very specific to hospital environments. And even with the N95 mask, we usually now wear a face shield in front of it. And so again, the masks don't protect the individual wearing it, it protects other people around them. And I'll stop at that point and ask if there are any questions that anybody has. We can go on a little bit more and talk about vaccines, diagnoses, and treatment if folks want to.
Yes, we do have a couple of questions. In the chat, one of the questions says, great information. What are your thoughts about cancer patients and treatment during this pandemic? Also, those who refuse to go to the hospital or get tested because of fear of contamination.
Okay. Well, first, there are certain cancers that absolutely need to be treated and need to be treated sooner rather than later. Pancreatic cancer, for example, certain lung cancers, certain leukemias. There are certain types of cancer that can be delayed for a while. Breast cancer, for example, usually can be delayed for 4 or 5 weeks in terms of surgery. If it's estrogen receptor positive, we can give tamoxifen and actually delay it even longer than that. Once we get beyond the surgery, there's some women who get surgery after breast cancer. Get chemotherapy after breast cancer surgery. Some people who get chemotherapy after colon cancer surgery or after lung cancer surgery. We call it adjuvant therapy. These are people who have no known cancer in their body, but we give them chemotherapy anyway to treat small amounts of cancer that might be there that we can't see, to prevent people from relapsing a year or 2 years down the road. Yeah, in certain instances, when we're talking about adjuvant therapy, I would actually recommend people forego it right now. There are women who have small, I'll give you an example. A woman who's 60 years old, who has a 10 millimeter or 1 centimeter breast tumor that's removed. We will typically give her 6 months of adriamycin, Cytoxan, and Taxol if it's an estrogen receptor negative tumor. That woman with that age and that size tumor, we're giving them the chemotherapy because we take their risk of relapse over the next 5 years from 20% down to 10%. We literally treat 100 women to prevent 10 of them from relapsing 5 years from now. Keep in mind, if we don't treat the 100 women, 80 won't relapse anyway. So 80 are getting that chemotherapy and don't need it. We just don't know who they are. Now, I'm going to give someone a chemotherapy which increases their risk of getting the coronavirus, and if they get the coronavirus, increases their risk of doing bad, in order to help 10% of women over the next 5 years. That's a woman who maybe she ought to forego the chemotherapy because the coronavirus is a greater short-term risk than the chemotherapy is in terms of being a long-term benefit. And so every woman in that situation needs to talk to her doctor, needs to really measure what her concerns are about the coronavirus, her abilities to actually isolate, and what her concerns are about the cancer. And I can see a very reasoned person saying, I'm not going to take this chemotherapy right now because of this coronavirus epidemic. And we can do numbers for colon cancer, we can do numbers for lung cancer. And those are the people who maybe should not be getting chemotherapy. There are other people who do need to get chemotherapy. Keep in mind, there's a lot of leukemias and lymphomas that are medical emergencies. We need to treat them within the next 24 hours after diagnosis. Now, what was the other question?
The other question that she asked was also those who refuse to go to the hospital get tested because of their fear of contamination.
Oh. Testing. First off, the only reason to get tested, actually, I wish the president understood this now that he's decided to get tested every day. The only reason to get tested is if you are sick and we want to say it's coronavirus and not flu, or if you are an individual who is concerned, I might have this and I don't want to give it to other people. Testing has never saved a single life in this disease of the person who got tested. Testing saves people from getting the disease from the person who's being tested. All right. Now, I would advise people don't go to hospitals right now unless you absolutely need to go. If you think that you have coronavirus, call and make arrangements as to where you should go and how you should get there, because we're taking people in through a different entrance to keep from exposing other folks to coronavirus. I'm also very concerned, the number of people going to the hospital because of heart attacks, the number of people going to the hospital because of strokes, the number of people going to the hospital because of a number of common things has gone down dramatically. I don't think the number of heart attacks and strokes have necessarily gone down dramatically. I think people who have heart attacks and strokes are not getting treated right now. And that worries me tremendously. So people should avoid going to the hospital as much as possible. But if you need to go to the hospital, go to the hospital.
We have another question. It's in regards to immunocompromise. How are we defining immunocompromised? I'm a survivor of 2 years, and the concern is I'm having to go back to work. If I go back to work, I'm going to be interfacing with other people. What can I do to address this issue? My doctor won't give me a note saying that I am immunocompromised, and I'm concerned.
People who get chemotherapy have some degree of immunotherapy. Immunocompromise. Their immune system is compromised both during the time that they get the chemotherapy as well as even after they get the chemotherapy. Now, at what point after getting chemotherapy is the immune system back to normal? We really don't know. My own suspicion is that women who get chemotherapy for breast cancer are going to have something different in their immune system for the rest of their existence. That's my own suspicion. Now the problem is we don't have good ways to quantify that, and that's one of the reasons why many doctors are going to be hesitant to give a note to someone who's 2 years out from their chemotherapy. We just don't have a way to quantify those sorts of things. I would advise anyone who's in that situation to be very, very cautious and very careful. And there's certain things that people can do or bosses can do. I know the mayor of the District of Columbia, God bless her, decided that she didn't like the idea that a lot of people were passing by bus drivers as they get on the bus. And so she said, all bus rides in the District of Columbia are free and everybody enters and leaves through the back door. I don't want you walking by the bus drivers and breathing on them while you're walking by them. Some changes in how we normally work, I think, are necessary. But yeah, I think certainly people with leukemia and lymphoma are always going to be immunocompromised. That's one of the reasons they got the leukemia and lymphoma. And the treatment makes them immunocompromised. But even solid tumors like adjuvant breast cancer, many of us believe that there's always some immunocompromised, what's the verb I'm looking for? There's some degree of compromised immune system at all times after getting chemotherapy.
Another question we have is around masks and CO2. Are there any studies that speak to CO2 or carbon dioxide toxicity for long-term use of wearing a mask?
No, although the N95 mask is actually hard to breathe through. I mean, it's almost, for those of us who've had asthma, wearing an N95 mask can almost give you that sense of asthma, difficulty breathing out and difficulty breathing in. With the cloth masks, with the paper masks that we normally wear in the hospital, no, there's not a CO2 concern for that.
Okay. Another question. Thank you for this presentation. Dr. Brawley, for those who are metastatic or in ongoing treatment, what do you recommend about scheduling scans, CT, MRI, PET? Is there any utility in temporarily or postponing or given poor decisions being made at the federal and local levels? Should we assume that we will be living with this for the foreseeable future and just go ahead with regular scans?
Well, let me go backwards. I think that we're going to have this problem for at least another 1.5 to 2 years. Some of my friends who do infectious disease are not as optimistic about a vaccine as you sometimes hear on the news. I know some people who think there's a 50-50 chance we're going to actually have a vaccine. A vaccine would be the fastest way to get out of this mess. I also have friends who think that the only way we're going to get out of this mess is with herd immunity, which means 60 to 70% of people end up getting this disease, and those who survive it, the chain of transmission will be broken at some point in time. So I think we're going to, in terms of getting these tests, when this was first opening up 3, 4, 5, 6 weeks ago, I was telling people, screening mammography, surveillance CT scans after treatment, those are all things that we can put off for a month, 2 or 3. You don't need to be going and exposing yourself to the hospital to get those things now. Stay home. Now that we've been in this for 6 to 8 weeks and we're starting to learn a little bit more about the virus, I think people can start talking to their doctor a little bit more. And hospitals are doing things a little differently. For example, at Hopkins, we are seeing half as many patients as we were seeing 8 weeks ago. In other words, when I see patients, we would schedule them every half hour. Now we're scheduling one patient an hour. Instead of the patients waiting in the waiting room, we're telling them, go to your car, give us your phone number, we'll call you when it's your turn. We don't want you sitting with other folks in the room and possibly getting exposed or exposing other folks. So we're getting a little smarter at social distancing and the practice of medicine. So I would say, so my answer 4 weeks ago was avoid all tests that you don't need. Now it's talk to people, make sure that they have some system to minimize your exposure.
Are there any extra cautions beyond hand washing, masks, barriers, social distancing where possible that we should be considering when going for these scans?
I would ask that I would just make sure that people are cleaning the equipment. Sometimes you can end up with an employee who's having a bad day, who just sort of forgets that they need to clean down the mammogram machine. I actually went to a lecture earlier this week on sleep lab equipment, those nodes, those things that they put on people's heads when they do sleep studies and that sort of stuff, making sure that those things are clean, making sure that people are not getting things from EKG machines and that sort of stuff. I think it's very appropriate for a patient to express concern about their exposure and make sure that that this has been thought about, or everybody's thinking about it in healthcare right now. Making sure it's being thought about while you're there is what I'm saying. I think that's a very reasonable thing to worry about exposure. And all of us have got to worry about protecting ourselves from exposure to this thing.
What do people in remission need to be concerned, and what should they do?
People in remission need to absolutely be concerned, especially people in remission from hematologic disease, lymphoma, and people who are in remission from solid organ diseases who've gotten chemotherapy. Social distancing to the max, isolation as much as possible. Don't hang out in groups of people who you do not know. Especially don't hang out in groups of more than 10 people, but I'd even try to keep it smaller than that. The reason why I say don't hang out with groups that you don't know is if one of those people actually gets exposed to somebody else and they know that you're sick, maybe they won't come if you're hanging out in a smaller group, whereas people tend to forget and put their guard down when it's not people who they know and care about. And I'm very much into trying to keep cancer patients from getting exposed to this virus. Once cancer patients are exposed to this virus, there's very, very little that we can do. Right now, remdesivir is the only drug that we have out there to treat this disease. Remdesivir is an RNA, it's a drug that prevents RNA from replicating. It was developed by the people who developed some of the treatments for hepatitis C. And it was actually developed as a designer drug to treat Ebola, which is another RNA virus. Interestingly, it did not work in the treatment of Ebola. It failed. It went to clinical trial. Everybody was hopeful. Everybody thought there were ID doctors who just knew that this drug was going to work for Ebola, and it failed in clinical trial. Reason why we should do clinical trial. Now, the data in the clinical trial, the good clinical trial that was done on remdesivir, shows that people who get 5 days of it just as they're getting very sick with the coronavirus were more likely to be discharged from the hospital 4 days earlier. There was a trend toward less dying, but they broke the code and stopped the trial because they said, gee, people are getting out of the hospital and getting better faster. We don't want to continue this trial and let a few more people die so we can prove that it prevents people from dying. It was thought to be unethical to continue it. It was 11% of people who were getting the placebo died versus 7% of people who got the remdesivir, and people who got the remdesivir got out of the hospital on median was the 11th day after admission versus the 15th day after admission for people who got the placebo.
Next question. Some of the reasons for disparities in outcomes are systemic and can't be addressed immediately. What are the things we can do in the short term to reduce disparity in outcomes?
Yeah, really, really good point. And one of my friends who writes for USA Today, when the first discussions about the racial disparities came out, she said that her first thought was Otis Brawley screaming, "Well, hello." I mean, it's so obvious that this was going to happen to anybody who knows that there are disparities out there. The only thing that you can do in the short term in terms of the coronavirus is try to isolate as much as possible. Try not to get this virus. That's the only thing you can do in the very, very short term. In the long term, we need to work on the problem of health disparities. And by the way, I will go out on a limb here. I'm a big guy. I can take a hit, so I'm going to say this. Some of the people who are saying let's open up are saying it thinking that this is a Black person's disease and this is not going to affect white people. Some of the people who are saying let's open it up are saying it because they think this doesn't affect them. I got news for them as an epidemiologist. If you look at the trends in the United States, the next group of people to get hit are poor white people. You can think of Black folks as being the canaries in the coal mine, but it's about to spread into the white communities. I already noted earlier, it's going to come back. We're going to have a second wave. This is not like one huge tidal wave. This is kind of like the ocean where we're going to have wave after wave after wave. The next wave is going to be majority white.
Thank you for sharing that, Dr. Brawley. The next question is, while they are coming, would it be wise to take these new potential vaccines when available? Do you think it will be mandatory to take future vaccines?
My suspicion is that vaccine, if developed, well, number one, I don't think anybody's going to be able to get a bad vaccine out there. I just don't think that the news media and everybody else is going to allow a bad vaccine. I think that the science needs to be done, and the science needs to be done right to prove that the vaccine actually works. My suspicion is if we get a vaccine, we're going to end up with several different vaccines, and there's going to eventually be, maybe after some of us have gotten one, an argument that this vaccine is better than the other. This has happened with HPV. The first HPV vaccine was a double valent vaccine against 2 different HPVs. And then we had one that was against 4. Now we have one that's against 9. Each subsequent HPV vaccine is better than the last. I suspect that we're going to end up with that sort of thing with coronavirus if we get a vaccine at all. And my suspicion is it's going to be like the measles, mumps, and rubella and smallpox vaccines, that everybody is going to have to get it unless they have a religious exemption or they can prove they have an allergy to the vaccine.
Okay, thank you. During this pandemic, can we consider our advancements in technology such as 5G as a route to the rapid spread of the virus through electromagnetic fields and increased radiation? Yep.
Yeah, I've heard that. No, there's no evidence that 5G or electromagnetic fields has done anything in the coronavirus world, except it has helped us through following phone signals figure out how this thing has spread. I mean, you can actually look at the outbreak, for example, in New Orleans and outbreaks in other areas around the country by tracing cell phone signals of people who went to Mardi Gras and those people as they moved across the country to go other places. Where those cell phones started pinging again is where we ended up having some of these outbreaks. The Detroit outbreak is very much related to New Orleans, for example. The Chicago outbreak is related to New Orleans and Mardi Gras. By the way, when we talk about blacks getting this, you'll note that the black communities have gotten it. They got inoculated and it spread through the black communities. Again, because of the way that we live. One of the things I point out is we see a little in the press, we do see a little exaggeration about the black-white thing. For my favorite is people will say 14% of the people in Michigan are black, but 42% of the people in Michigan dying from coronavirus are black. Truth be told, 85 to 90% of all cases of coronavirus are in metropolitan Detroit in southeastern Michigan. Now, what you should be saying is southeastern Michigan is 35% black and 42% of the people dying from the coronavirus are black. But the news media has decided to say 14% of the people in all of Michigan are black and 42% of the deaths are black, because 14 and 42 sounds a lot better than 35 and 42. There's still a disparity, but we're exaggerating the disparity.
Yeah. Another question. Let me scroll down. Just kind of go through their question. Okay, willing to answer. What do you think is the most appropriate long-term strategy for immunocompromised patients in the worst case scenario, i.e. no vaccine ever? Do we need to stay socially isolated until population herds immunity? And are there any estimates currently on how long that might take?
The herd immunity thing, if it happens, is probably going to be 3 years. And there's actually another very important question buried in there. We may end up with a vaccine that certain immunocompromised people cannot take. It is possible that we have a vaccine early next year But people who should not take that vaccine are people who have HIV disease, people who have leukemia or lymphoma, or a history of leukemia, a history of lymphoma. That is indeed possible. I worry about that a great deal. Of course, I also told you, I also worry that we won't have a vaccine at all.
Next question. Do we know how many cases of COVID are cancer patients?
We don't know how many cases of COVID are cancer patients. However, there's some really good work that came out of Wuhan, China. There's actually been some publications that just observed the cancer patients who got COVID in China and what happened to them. And the answers are virtually everyone who had any kind of cancer that involved their lung who got the coronavirus died from the coronavirus. That is, people who had lung cancer or people who had metastases from some other disease to their lung. If they got the coronavirus, they died from it. There were no survivors whatsoever. Among women who had breast cancer, who had had adjuvant chemotherapy, there were some survivors, but again, the disease was pretty harsh on anybody who had a history of chemotherapy.
And the last question that's come in thus far, with all of the hand sanitizer that we're using, are there any risks to our health?
Yeah, that's an interesting point. You know, one of the studies that we had been talking about in the colon cancer risk world about a year ago, before hand sanitizer became really, really common, is among people who use, doctors and nurses have to use hand sanitizer going into every hospital room now when we're working in the hospital. The GI docs could actually do a colonoscopy and actually aspirate some of the liquid inside people's colon and send it to a laboratory, and the qualitative analysis chemist could find some of the chemicals in the hand sanitizer ended up in people's colon fluid. It got from your hands into your bloodstream and ultimately ended up in your colon. Okay, now how this is important is one of the things that we've been talking about in terms of colon cancer is what kind of bacteria grow inside one's colon. And if you've got hand sanitizer in your colon, it's killing off some of the good bacteria. So there are some worries about this. We don't know and understand them enough, but that is a really exceptional question. It is possible that all this use of hand sanitizer in the future could increase our colon cancer rates by getting rid of the good colonic bacteria.
I'm getting thumbs up.
Hey, soap and water. I have not been able to come across a study that says that soap and water doesn't work for the coronavirus, and I haven't come across a study that says soap and water is bad for my colon health. Wow. It's cheaper too.
This has been great. Does anyone else have any other questions? We'll see if anyone else posts any other questions.
Since we have just a few more minutes, let me just tell you some exciting things that may be on the way. We already know that remdesivir, this RNA truncator, this thing that stops RNA replication, seems to improve people's outcomes with this disease. The next group of studies are actually looking at some of the people who die, many of the people who die from this disease have what's called cytokine storm, where they have all kinds of interleukins and all kinds of inflammatory things going haywire from their white cells. And they end up with their hearts racing. Some of them have heart attacks because their hearts are racing so much from this cytokine storm, this total body inflammation. The Chinese actually early on tried to treat this inflammation with steroids and it didn't work. Well, we have a couple of drugs that come out of CAR T cell therapy, come out of rheumatoid arthritis therapy that actually block some of these cytokine storms. And those studies have actually also been positive so far in good clinical trials. And by the way, we wasted a lot of time not doing good clinical trials because of people advocating drugs that they had no business advocating. Now, let me just leave it at that. But in good clinical trials, we've got some of these cytokine blockers that seem to be looking good. The next group of studies you're going to hear about are the outcomes of people who got remdesivir plus these cytokine blockers to see if that helps them overcome this problem. And we may actually finally have some good treatments for this disease.
Awesome. Good. We got a lot of feedback saying thank you. Thank you so much. This was great. We did have one, but I think you flipped it around. They said it feels a bit pretty discouraging kind of hearing the message about being immunocompromised. Is there any hope that you can give us? I think you were going down that path.
I understand. Unfortunately, I see Shelley Nassau there. She likes to explain to people that I have this bad habit of telling people the truth. and in the case of if you are immunocompromised, my best advice is stay away from as many people as possible. And the people who you hang out with, make sure that if they have any inkling that they might be sick, that they won't hang out with you. That's the best protection that we have right now.
Yeah. I said, thank you, Dr. Brawley, for this presentation. I appreciate the truth, even when it's initially hard to hear.
Thank you.
We need truth these days, especially when people are peddling untruth. Yes. I mean, you have, our president and you have the CDC, and there's like two different mindsets and two different means of communication. And it's like, well, what do you trust? What do you believe? And it's a challenge for patients.
The folks at the CDC, especially the worker bees, I've known those folks all my life, going back to when I was a resident and then when I was working at the National Institutes of Health in the 1980s and 90s. The worker bees at the CDC are wonderful people. They know how to handle these diseases. They've been trained to do it, and they've been doing it all over the world. They're the people who got on top of the Ebola epidemic recently. These are the guys who eradicated smallpox from the world. Okay, they know how to do this. We just need to let somebody let them do it. Now, the other thing is they have been terribly underfunded for a long while. There's been an erosion of the public health system. It started before this administration. It actually goes all the way back into the Ford and Carter administration, that the CDC and the public health infrastructure has been eroded. It's been eroded more in the last 3 years than in the last 20 years before that. But we need to have a strong CDC, and we need to get out of the way and let those folks tell us what to do.
Yeah. That's good.
I'll shut up now.
No, that's good. Thank you. Thank you. I'm going to see if anyone else have any other questions before we close out. I know there's a paper that someone mentioned that comes out of the CDC. It's COVID-19 and cancer, lessons from preliminary data from a meta-analysis on COVID-19. And it states that about 2% have a history of cancer. So that could be something that we can actually share with those who have an interest in that paper. We can share that out as well. All right. Well, I don't think we have any more questions, but thank you so much, Dr. Brawley. This was a big help to all of us. I mean, thinking about all the hand sanitizer we're using and just, having our eyes open to just being even more mindful of all the things that we're doing. We just want to just again say thank you so much from Mile Matters and Cancer Awareness Network. We just really want to say thank you for joining us, for giving this talk, and I hope that everyone finds it to be extremely helpful.
Thank you. You take care.
Awesome.
Stay
Thank you.
safe out there.